told when we're live, and then I will introduce you. All right, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Mitchell. Dr. Clifford Mitchell is the Director of the Environmental Health Bureau in the Maryland Department of Health's Prevention and Health Promotion Administration. He directs all bureau activities, including food protection, asthma, lead and healthy homes epidemiology and home visiting programs, as well as violence and injury epidemiology and prevention programs, including occupational health surveillance, regulatory programs for pools, youth camps, and community housing settings. Dr. Mitchell joined the department in 2006 after 14 years on the faculty of the Johns Hopkins Bloomberg School of Public Health. Dr. Mitchell received his bachelor's degree from Williams College, a master's of science from MIT, a medical degree from the Case Western Reserve University School of Medicine, and a MPH from the Johns Hopkins University School of Public Health. Dr. Mitchell's research, practice, and publications focus on indoor environments, climate and health, environmental like occupational surveillance, as well as environmental health workforce development. And now it is my honor to request Dr. Mitchell to begin today's session. Thank you.
Manahil, thank you so much for that very kind and mostly true introduction. It's really a pleasure to be here with you. And what I'm going to do is I'm going to share my screen. All right, and do this and do this. It's all very clever. And now do that. All right, so Manahil, can you see my screen okay? Is it full size?
Perfect.
Fantastic. All right. It's really a delight to be here with you. I apologize if there are helicopters flying overhead. It's the Baltimore Marathon today. And in fact, the streets are filled with people who are out running, enjoying the October sunshine. You may hear an occasional cheer go up from time to time as people cross the finish line. So that might actually be a good metaphor for what we're going to talk about today, because as medical students and people who are aspiring medical students, you may feel as though you're in a marathon also. And it's really important, and I will try to point out that this is a marathon, it's not a sprint. So what I hope to share with you today, based on what Manahil asked me to do, is talk a little bit about how you can take a very long, circuitous, indirect, meandering route to your career, and not necessarily a linear path. Again, to extend the marathon analogy or metaphor, sometimes it's really about not just the journey, but the stops along the way for water and a little break as you're continuing through the marathon course. So I'm going to try to share with you today how I got to wherever I am at the moment. And I say that because this has been just a really fun ride for me, but it is not one that I necessarily would have anticipated right at the outset. So let me talk to you a little bit about environmental health. And as you heard from Manahil's introduction, it's a very varied career with a lot of different elements. We talk about everything from environmental causes of cancer to the social determinants of health, many of which are rooted in the physical environment, as well as things like food protection, swimming pool safety, injury prevention. And when I say that no one in their right mind would do this job, I say that in the spirit of fun, but I do want you to understand that people don't usually come to this career having thought it all out ahead of time. Many people, I won't say stumble into the career, but many people do come to this sideways. And what they learn when they get here is that it is far and away the best job in the world, at least to me. But if you ask people what is environmental health, many of you as students probably took courses in environmental health. And I suspect you all had long discussions about environmental biology, the role of oil and peak oil and climate change and other things. But it's important to remember what the origin of environmental health is from a public health point of view. When this country was originally settled, before this country was originally settled, in Europe, in Africa, in Asia, people needed to learn how to live in a hostile physical environment. Because as you all know, for a number of reasons, the universe is not exactly a friendly place. There are all kinds of hazards, physical hazards, biological hazards. One of society's jobs was to try to help us understand how to avoid dying on a regular basis. Now, you all, as either medical students, physicians, public health professionals, or people who have just grown up, know that the way we have learned to live in a physical environment that is somewhat hostile is to build homes, to provide heat when it's cold, to provide cooling when it's hot. We've learned how to provide safe drinking water. We've learned how to eliminate waste safely so that it doesn't become an infectious hazard for those of us who produce waste, which is pretty much everybody. We have not always done a good job at all of that, but that really is the job of environmental health. It is to help us live and accommodate to a physical environment in which safety, injury prevention, protection from infectious diseases, many of which are related to the ways in which we live and organize ourselves and work and play and use the bathroom facilities. Our job at environmental health is to make people able to enjoy themselves, live full, productive lives to the best of their ability, and not have to be concerned unduly with those physical hazards. So when I say that this job is more fun and rewarding than anything else that I can imagine, it's because, you know, when you're thinking about a medical career, you probably are thinking of going into surgery or family practice or obstetrics and gynecology. It's less clear what the role of medicine is and a medical education to environmental health and public health. And the reason for that is, to some extent, we've lost some of that connection between our physical environment and ourselves by building up a very, very highly structured, artificial, constructed world. But at the end of the day, you can't escape thermodynamics. You can't escape the law of gravity. And you can't escape the fact that we are living in a world in which, despite our best efforts, there is still a need on a regular basis to think about the way in which we live sustainably and in harmony with our physical environment, as opposed to just deciding arbitrarily we are going to make the physical environment what we want it to be. Because at the end of the day, that actually doesn't usually work. Instead, we need to reach an accommodation with our physical environment based on our understanding, our science, our medical evidence. But a lot of that is about human behavior, as well as things like how we organize our built environment, what we use for transportation, and so forth. So what does that have to do with medical school, you ask? Well, good question. Let me go back a little bit to let you know how I got here. So as a high school student, I was very interested in science, as I'm sure many of you were. And when I got to college and was an aspiring chemistry major, I spent some time working with a chemistry professor looking at the impacts of the Toxic Substances Control Act of 1976 on innovation in the chemical industry. And that and some other things led me to take some time off while I was in college. And I had a terrific time working, some of you may have heard of, Argonne National Laboratory, which is a nuclear research laboratory in Illinois. And I did environmental chemistry. And then I went to Washington, D.C., where I served as an intern on the House Energy and Power Subcommittee. The House Energy and Power Subcommittee was a subcommittee that dealt with everything from nuclear issues, which is sort of how I got there, to low-head hydroelectric power, to nuclear arms control and safety. And so if you can explain to me how all of that is related and tied together, you're doing a better job than I am at this lecture, because these were things that appealed to me. I enjoyed them. They were not exactly part of the pre-med curriculum. And although my father was a doctor, actually in public health, I wasn't actually thinking about medical school at that time. So what I did do after graduating from college at Williams College was I did 2 years of a master's in technology and policy with Nicholas Ashford, who was a true mentor at MIT. He had a background in occupational health policy and occupational safety of health. And that prompted my interest in occupational health and safety. And I continued to pursue this sort of weird roundabout way of trying to do policy as well as chemistry, as well as environmental science all at the same time. I ended up, after graduate school, working for a couple of years in Cleveland, Ohio, at an architectural and engineering firm, where I was essentially doing environmental consulting, sort of on the road construction, potential impacts of road construction on runoff pollution, which was a project funded by the EPA. So I spent several years in Cleveland doing that. And I came to a fork in the road and I decided to take it, to quote the poet, Robert Frost. When I had been in working in the Cleveland architecture engineering firm for a while, it occurred to me that I probably had to fish or cut bait and decide what my actual career path was going to be. And so I had before me basically three choices. I thought, well, I could go back to graduate school and get a degree in a PhD in toxicology, which was very appealing because I actually like laboratory science. I could go to medical school, for which I had some real world examples in my father and others, but that was a longer path. And then I was seriously considering law school, and I went so far as to take the law school admission test. I will confess that I actually did better on the law school admission test or law school aptitude test than I did on the medical college admission test. So if we'd gone simply by the scores and predictive power of the scores to demonstrate aptitude, I would be now sitting before you as an attorney at law, which would have been probably a profound loss for the profession of law, maybe a gain for the profession of medicine, but we'll never know, because after thinking about it long and hard, I decided to go to medical school. One of the reasons I decided to go to medical school and I applied to Case Western Reserve in Cleveland was that there was a faculty member there, Herbert Rosenkrantz, who was doing some really interesting work in computer assisted predictive models of carcinogenesis. And I got into Case Western Reserve. Now, I will say this about Case Western Reserve at the time. I don't know if it's still true, although I attended my reunion recently, and I think it's probably partly true. The medical school class at Case Western Reserve was full of bent arrows. And by bent arrows, I mean there were students who were sort of straight arrows. They were undergraduate. They knew what they wanted to do from approximately 5 weeks in utero, it appeared. And they had gone in a nice linear path, straight from, basically straight from birth all the way through to medical school. They were very nice. They were very smart, much smarter than I was. And they were very good students. Then there were the bent arrows, and there were a bunch of us who were bent arrows who had a considerable number between us of both years and lived experience that were really, really different. We had nurses who had done work as nurses in migrant health centers. We had people who had done all kinds of really interesting things. They tended to be a little bit older. They tended to be a little bit more eclectic in their backgrounds. We bent arrows, and I included myself in that. We did not have a club, but it was nice to have other people in the school, in the class, who were really interested in and had experienced other things. And it was a nice addition to the class. Many of them were also very, very good students. Now, I mentioned before that I took the law school admission test. I did allegedly study in medicine in medical school, but I will say we had a great time as a class. We had a jazz band, which was a terrific source of recreation. We had some rather irreverent students. There's a famous story about my class, which I will not repeat so as to avoid getting other people in trouble. But we had a class that had some hijinks associated with it. A couple of people did end up having to well, let's just say that it was a class that went down, I believe, in medical school history at Case for a number of reasons. One of the things that we had was a very politically active class. I was a member, along with many other students, of the American Medical Student Association, and I happened to become involved, as you might imagine, in the occupational health section of the American Medical Student Association. So, when we were in medical school, the U.S. Occupational Safety and Health Administration, which was created in 1970, issued and then subsequently retracted when a new president came into office, a rule that would allow workers to know what chemicals that they were exposed to, the so-called right to know law, which is now, or right to know regulation. The right to know about chemicals is now really sort of taken for granted. Many of you, if you were in laboratories, you probably received training in your chemicals and chemical safety and chemical handling. You probably are familiar with safety data sheets or material safety data sheets. Those were created by that regulation. So when the incoming administration retracted that rule because they didn't like it and then reissued it, one of the things that they did was they said, well, okay, maybe workers have a right to know, and maybe health professionals do, but we're going to enshrine in the regulation the right for doctors to know about the chemicals that their patients use and to be able to get those from the companies, they did not extend that same privilege to nurses. So we thought, a group of us, that was unfair. And under the auspices of the American Medical Student Association, a lawyer friend of mine and I wrote a brief in a case called United Steelworkers v. Octor. Thorne Octor was the head of the Occupational Safety and Health Administration at the time. We wrote what's called an amicus curiae brief, which is Latin for friend of the court. And that brief, which argued that that nurses should have the right to know what chemicals they work with, actually was filed with the U.S. Supreme Court and ended up being cited. I'm proud to say that the brief that we wrote was actually a footnote in the decision in United Steelworkers v. Octor. It is my only foray into law and the practice of law, but it was really a great deal of fun. And yes, it happened. I can't remember whether we were in the unit on neurology and the nervous system, but it was, I think, it was a memorable event, and it really helped crystallize for me why it is that it's important for health professionals to be active beyond simply the practice of medicine. The other thing I did while I was in medical school, and I had mentioned before this, Professor Rosenkrantz and a colleague, Gilles Klopman, who were doing work on some of the first work really on computer structure activity relationships. I got involved in a project with them in which I spent a long time in the library looking up articles on cancer caused by polycyclic aromatic hydrocarbons, which, as you probably remember, are these very complex multi-benzene ringed chemical compounds, which in certain configurations like benzanthracene, chrysene, benzoate, pyrene, create what's called a Bay region. And the Bay region is it's a spot where basically it allows the chemical to intercalate with and bind with and alter the shape of DNA. And so this was thought to be the Bay region, is actually now pretty widely recognized as being a structural reason for carcinogenesis. And it was a terrific amount of fun to work on that project with those professors. But it really was sort of thinking about the environmental sources, because PAHs are caused by combustion, as you know, how it is that you can think molecularly about pollution and understand the relationship between physical structure, conformation of a chemical, and dose response when thinking about how it then affects the carcinogenic potential of a chemical. So that was a terrific amount of fun. But eventually, like everything else, med school gives way to internship and residency. And I thought long and hard about it. I knew about occupational medicine as a career, but I decided that it was really important as part of that process to do a clinical residency. So I came to Baltimore and did an internal medicine residency at what is now Johns Hopkins Bayview Medical Center, but at the time was Baltimore City Hospital and subsequently Bayview Medical Center. And this was a really interesting hospital because it was acquired by Hopkins just before I got there. So we did have Hopkins faculty, but this was a city hospital, and it's a city hospital in East Baltimore. And for those of you who know East Baltimore is basically Steeltown, USA, like Cleveland, like Pittsburgh. It was the home of Bethlehem Steel. And it was at that time very much a steel town with a lot of steel workers, also crabs. It was a really, really good introduction to occupational medicine and the relationship between work and health. So, we knew that on Thursday evenings, we were likely to get emergency department admissions for pulmonary edema. And it was pretty much likely that the patient who would come in would be, number one, a steel worker or associated with the steel industry. Number two, quite frequently would have earlier that evening consumed crabs, which are a delicacy and a staple here in Baltimore, with Old Bay seasoning. And if you've ever had Old Bay seasoning has a pretty hefty sodium load associated with it. And so pretty much Thursday evenings, 2 in the morning, 3 in the morning, it was not surprising to have somebody come in full pulmonary edema and need diuresis. And oftentimes the precipitating factor was a meal of crabs. I learned a couple of things in that experience. Now, this hospital and this residency program is also famous for and well known for being on the forefront of the idea that physicians should go into homes. And so we had a home visiting program well before it was fashionable. Randy Barker, Phil Zeev, and John Burton, who wrote one of the textbooks on ambulatory medicine, all very much believed that you ought to go into people's homes to understand their environment and to understand where they live, and that would be the key to being a good physician. And so I learned that no one was ever cured by a Swan-Ganz catheter, but I did learn the value, as Ramazzini said, of going in, sitting down on a 3-legged stool and looking at what people did in their natural environment as a way of understanding how it is that they came to be in the health that they were. And, for people who talk about the social determinants of health now, it really points out the social determinants of health is not a new concept. It's an old concept, which is being reinvented, but it goes back to the idea that you must understand that to understand a person's health fully, you need to see that person in the environment in which they play, they work, and they live. So that led me inevitably, and you can sort of start to see that this is a very long, circuitous path, but it does sort of have maybe a direction, to occupational medicine training at the Bloomberg School of Public Health, which at that time was the Johns Hopkins School of Hygiene and Public Health. And that's where all of this stuff started to coalesce and make sense and fit together. And early in my career, I got some advice from during both my residency and my early work on the faculty at the School of Public Health, because once I finished, I stayed on as a junior faculty member. And I got I got some wonderful advice from the Committee on Admission, Appointments and Promotions, which meets early in a young professor's or young faculty member's career with the young faculty or junior faculty to give them guidance and help them understand how appointments and promotions work. And the advice that I got at that time from the Committee on Appointments and Promotions was the importance of focusing your career, becoming deeply immersed in some subject so that you had a long CV with a lot of publications, and you really were sort of, people associated you with this thing and you were really known for it internationally. So that was the advice I got. I think you can see already that for me, part of the joy and the fun of this career is the idea that it is eclectic, that it does have many diverse elements. It has a policy element. It has a medical and a clinical component. It has a science component to it. It has a legal component to it. I don't want to say that I was at odds with that recommendation, but I think you can tell from what I'm saying that the joy of this profession is that it's a discipline in environmental health, but it has very many aspects to it. So for me, the fun is really in the practice of environmental health. And that, I think, was part of the reason that when I ultimately left Hopkins to come to the state in 2006, it was really because during my tenure at the School of Public Health, I spent a lot of time, I did research, I published some papers, I wrote grants, I did all of that stuff. But really, I really did enjoy taking that knowledge and applying it in practice. So I worked with schools on indoor air quality problems. I worked with governments. And then my cursor went crazy. But while I was still on the faculty, the world changed. And that was in 2001. So as all of you, I'm sure, are familiar, 9/11, 2001 was the event that really reshaped the generation. For me, it was not just that event, but a subsequent event that got a lot of attention at the time, but has, I think, largely been overshadowed by the events of 9/11 itself, and that was anthrax, which was weaponized and which killed 2 postal workers and also a number of other people. And as a faculty member, all of a sudden, I became involved with the Postal Union because Brentwood, Maryland is where 2 postal workers died. And so I worked with the Postal Union on issues related to personal protective equipment and response. I became involved with the National Institute for Environmental Health Sciences in a large project looking at hazardous waste and hazardous waste training for workers under what's called HAZWOPER, the Hazardous Waste Operations and Emergency Response Regulation, and did a lot of work on and published some papers on how to think about surveillance, not just for primary workers, but for workers who are involved in cleanup activities. And a good friend of mine, Dr. Jacqueline Moline at Mount Sinai, was responsible for the surveillance program for World Trade Center workers. So there was a lot of discussion in the occupational medicine community about the importance of occupational health and safety, not just for routine, run-of-the-mill, everyday jobs, but also some of those incredible emergency response efforts that now, unfortunately, we're seeing increasingly frequently as a result of climate change and extreme weather. So I mentioned that in 2006, off I went to the Department of Health to head up the what at that time was the Office of Environmental Programs. Once upon a time, the Department of Health actually held most of the environmental programs for clean water, clean air, toxic materials in the state. And then in Maryland in 1987, the state created the Department of the Environment. But what was left in the Department of Health was all of the stuff that was related to environment that was not regulatory and not with the Department of Environment. So my tenure there, I'll sort of walk through some of the day in the life things that we did, and I've participated in. But I will say that it has been just a tremendous opportunity to work on a whole variety of important environmental health problems that have really, I think, afforded me an opportunity as a physician, a clinician, and a public health person to apply all of my skills across a broad range of problems. So one of those was in 2007, several months after I arrived at the department, the then Secretary of Health, John Colmers, asked me to come to his office. It was the first time I'd met him. I was trying to figure out what I had done wrong. And he said, well, we have this thing, the Clean Indoor Air Act. The state has enacted a law in 2007 that is going to prohibit smoking in indoor areas open to the public. I'd like you to write the regulations for that. That became a multi-month project, which involved public hearings, stakeholder input, learning how to write regulations, and learning how to work collaboratively with many other centers, the Tobacco Prevention Program within the department, the University of Maryland Center for Public Health Law, which was headed by a couple of folks who are good friends, Kathy Hoke and Will Tilburg, who helped tremendously in helping to craft and shape and provide a structure for the regulations. Our Office of the Attorney General, bunches of people. And that was a really a sort of a crash course in not only the regulatory process, but also a very public, very visible, first time the state had committed to basically banning smoking in indoor areas open to the public. And I'm very proud of the fact that we survived our legal challenges, and that regulation is still on the books and has really, we've had our several anniversaries of that act and the regulations. And I'm, very gratified that that was a way to take indoor air quality and my work on indoor air quality, which I'd done at Hopkins, and transfer it to the public sector. Another area where we've been very, very energetic and very busy is in asthma, lead, and children's environmental health. And I'm going to talk more about that a little bit, but this is an area where we know children are not young adults. They are actually children. They have different physiologies. They have different physical characteristics. And we have spent a lot of time trying to improve children's health. And I'll talk about some of the programs that we've done to do that. I mentioned cancer cluster investigations and public concerns about cancer. That's been a collaboration with the Maryland Cancer Registry, which has been incredibly important to communities that are concerned about cancer rates and the possibility that their environment somehow is associated with an increase in cancers. I've had a chance to work on lead and lead testing regulations. I mentioned emergency response. I've become involved more recently, although it's really sort of an old, dating back to some of the work on computer-aided structure-activity relationships with Herb Rosencrantz and Gilles Klopman, there's a renewed emphasis on informatics, and I've been working on informatics and environmental health, and a project that's really, really fascinating. And then a project that, and an area where I consider this talk today to be part of this work, which is environmental health is a field which is, I think, the most fun, most satisfying career you can have in public health and indeed in medicine, personally. But part of that responsibility is to make sure that there are people coming into the field who are as excited, knowledgeable, and have as much fun with it as I think I've been able to have. So I'm hoping that there are at least a couple of you who view this, who decide that this is where I want to spend the rest of my career, or at least a good chunk of it. So let me just talk about a couple of these and give you some examples of what some of the work is that goes on here. So I mentioned it is not unusual for us to get a couple of times a year. It's been more frequently recently, up to one a month or so, a community concern about something where there's a concern that, is there a problem in my neighborhood, in my town, in my wherever geographically, with cancer rates, either for specific cancers or cancer generally. And as either medical students or physicians or health professionals or people, that we've made tremendous strides in infectious disease over the past many decades. A lot of that is due to vaccines. Some of it is due to better clinical care. A lot of it, frankly, is due to environmental health, because one of the big causes of infectious diseases is poor sanitation and poor physical environmental factors. So I think the environmental health people can take at least as much credit, certainly in terms of their contribution. Advances in hygiene, sanitation, and environmental health are significantly more important, I think you'll all agree, than advances in clinical medicine. Although advances in clinical medicine are important, and I don't mean to diminish them, but I think recognizing the value of environmental health in that progress is really important. But so when people ask, is there too much cancer, or is there an excess of cancer, or is there more of one type of cancer, or is cancer occurring people too young? That's a really tough question to answer. The questions come up a lot. They get answered much less frequently. And to answer those questions requires a blend of epidemiology, toxicology, clinical medicine, public policy, psychology, sociology, and a lot of other ologies. So let me just give you a couple of examples. When we look at community cancer questions, we use guidance that the CDC has put out. Actually, they've just re-proposed that guidance, and we'll be coming out with a new version of this fairly soon. Some friends of mine and colleagues from the environmental health community played a very, very important role in that, and I can't say enough about Patrick Ricey, a former colleague at the Johns Hopkins Bloomberg School of Public Health, who has ably led the National Center for Environmental Health at CDC for a number of years now, and has really led this effort to update this guidance for community clusters. But we've adapted that here in Maryland, and I participated in that. And so we have a way of managing and responding to these concerns that involves a very close collaboration between the Cancer Registry and the Environmental Health Bureau. So this little collage shows you one of those multi-year investigations of cancer in Frederick, Maryland. And this was a case where those of you who may know that in Frederick there is Fort Detrick, which is the home of the U.S. Army's Institute for Infectious Disease, USAMRID, and the NIH has a laboratory facility there. And historically, there's been a lot of concern in the community because this was a facility that over time has pioneered the development of Agent Orange and other chemical agents used at one point in chemical war, in warfare. The people who live in that area have always had, historically, it's a big institution, and questions have arisen from time to time about the health implications of this large institution. Well, at one point, a query came in to us about cancer concerns in this community. That prompted, for a number of reasons that I won't go into, a multi-year investigation to look at cancer rates closer to and farther away from, geographically, Fort Detrick. That study, which is on our website, was also had a follow-up study. And then it actually got to the point where the National Research Council of the National Academies of Science evaluated the work that we did. And I'm gratified and pleased that the findings from an independent, really top-notch bunch of epidemiologists on the Board of Environmental Studies and Toxicology were supportive of our findings, our methods, and our conclusions. And that was very gratifying because usually, you release these things in public, people will criticize them, and we had a lot of criticism. But it's nice to have that sort of independent assessment of a body of work and confirmation that the thinking and the science and the epidemiology and the public health practice were sound. And I think it's really, really important for us as both public health professionals and as clinicians and as scientists. It's really important to have that independent assessment to know whether or not you're on the right track or not. So it's, in your own work, you'll probably find similarly that it's a little nerve-wracking to have somebody tear your work apart, but at the end of the day, it makes the work better. We did another project in Poolesville, Maryland, looking at the possibility of radionuclides in drinking water, and did that have some impact on cancer rates in the community? Again, I think it was a very complicated analysis. At the end of the day, we were able to engage with the community. And I want to say one thing about that process, which is, whether or not you're confirming or not confirming a particular thing or finding, when you engage with the public, one of the most challenging parts of this job is communicating risk and communicating the work that you've done. And when I do that with a group of people in a community, for me, that is basically a clinical encounter. So where you may think about a clinical encounter in an office, and you think about your interviewing skills, and you think about making sure that you're actively listening and that you are responding to what people are saying, and you're not cutting them off, and you are hearing them out, and you are acknowledging what they say and repeating it back to them so that they know you have understood what they're saying. All of those techniques are essentially what happens when your patient is a community. It's a little bit more challenging sometimes because there are a whole bunch of people in the room, but it's very valuable training. And I really want to emphasize the importance of good listening skills and good interaction skills with patients, because you will find that those are similar to the kinds of skills that go into working with a community as well. So that's some of the work on cancer investigations. Sometimes things just happen and they're kind of funny and you can never predict what's going to happen. So 2012, we wrote an application to the CDC to do work on climate change. I'd been involved in climate change work even at Hopkins, and I carried that over into the Department of Health. You may know that climate change now, people talk about the health impacts of climate change, but back at that time, it wasn't such a big thing, and the CDC was trying to get people involved in that, and I was really interested in it. So we issued our Maryland Climate and Health Profile Report in 2016. And we spent time, I worked with colleagues at the University of Maryland School of Public Health, Dr. Amir Sapkota, who had actually been a student of mine at Hopkins, and then went and has done fabulous work. And I really enjoy collaborating with Amir at the University of Maryland. And we together did this climate and health profile report. His group did a huge amount of really, really good work. And then I got a call to show up for a panel discussion on climate and health at Howard University. And when I got there, it was a little unusual because I was ushered into a room. And I don't know if you can really see, I'm this guy here. Maybe you can't see the guy in the picture. Well, the panel you can see on the, I don't know which side of that is, the panel sitting together at the table facing the audience. So all of us are facing the audience, and I'm the person who's in the middle in the sort of light gray suit or light gray blue suit. But the other picture there is with the room we were ushered into before the meeting, before the panel. And so I sat down with a bunch of people, Tyra Stevens-Banks from University of Pennsylvania, who's an expert in asthma, and I've collaborated with her subsequently, and the Surgeon General, and the person facing me and directly across from the table from me on the other side, you may recognize, was the President of the United States, who wanted to have a chat with a bunch of us about climate change, asthma, and public health. And so for about 45 minutes, we had a chat. At the other end of seated down, a couple of people from him was the head of the EPA. You know, sometimes these things happen not because you're looking for them, but because there is a recognition of the need to incorporate science and public health into policy. And the president was very interested in sort of thinking about the policy implications of asthma and climate change. And it was first of all, he was smart, he was informed, asked great questions, and I've kept this picture for obvious reasons. You know, I mentioned that we get involved in hazardous waste. I did that with anthrax. You may remember Ebola. I collaborate with a group of people across the country who are, like me, responsible for regulating special medical waste or infectious medical waste, and trying to figure out how to do that in the context of Ebola is a really challenging problem, which we spent a lot of time dealing with in states when we had Ebola, and Maryland, like New York and Texas and some other places, had firsthand experience in trying to figure out the complex regulatory framework and public health implications of Ebola waste. One of the things that we dealt with there was the public perception that even if you burned waste containing Ebola, that somehow landfill operators did not want to have the ash from that high temperature incineration. And so that really led to some really complicated problems in terms of managing the waste stream. Another sort of interesting public health problem. I don't want to suggest for a minute that things happen quickly in public health. So let's just put that to bed. That does not happen. It takes a while for things to happen, but they do happen. So take the example of asthma and the example of lead. So in 2015, as a result of the Affordable Care Act, we and a number of other states had conferences on how to think about improving asthma care and moving upstream to do more prevention activities in people's physical environments. That led to a collaboration between my office and our Medicaid office, which is also located in our Department of Health. And we discussed a plan to use home visit, to essentially create a home visiting program for kids with moderate to severe asthma using funding from the Maryland's Children's Health Insurance Program. At the same time, in the same time period, we had actually also started a review of our lead testing strategies, which at that time was based on zip codes with older housing. And we decided that as a result of this epidemiologic review, which showed that we were missing kids potentially in areas that were not necessarily, that didn't necessarily have older housing, but where there were still kids who were lead exposed, we changed our regulations in 2015 so that all areas of the state would be considered at risk. And that meant that every child in the state had to be tested at age 12 and 24 months for lead. And as a result of those sort of two parallel stream tracks, in 2018, we launched a new program in 9 of our most populated county health departments to do home visiting using CHIP funding. CHIP is the Children's Health Insurance Program, and it allowed us to do this as a way of providing additional services and altering and improving the physical environments of kids with asthma and or lead poisoning. Not everything works. Just be prepared for stuff to fail. Since 2009, I have been trying to improve our environmental health workforce through a variety of means. At this moment, we are facing a crisis in the environmental health workforce. Not all of it is stuff that I can control. Most of it I can't. I would say this is a problem I have not yet solved. So it takes a long time for stuff to happen, and it doesn't always happen, but you keep at it. And then COVID. So in March 2020, we basically, because there aren't a lot of clinicians in the Department of Health, we basically divvied up responsibility for various parts of the economy and society. And I got business, corrections, and higher education. And I've engaged with those institutions ever since, and I'm still engaged with those institutions, looking at developing guidance, developing enforcement. I've had to use my legal training. I've had to use my policy and risk communication policy. You all know the story of COVID, so I won't repeat it. It's just to say, engaging with the private sector as well as corrections, you have to understand people where they work. So my career in occupational medicine has served me quite well in that regard. As well as things like, how do you clean and what do you do? And, what kind of cleaners do you do and use, and personal protective equipment. So all of that is sort of building on my earlier career. And then finally, informatics. I'm now engaged in a project where with our home visiting program and with environmental health, we're way behind where infectious disease is with things like electronic laboratory reporting, having the electronic health record and or EMRs have data that is useful for environmental health. So we've got a long way to go in informatics, and I'm engaged in a project where we're trying to essentially create a model for environmental data that is equivalent to the case-based personal data that is used in that has HL7 as its underpinning, or laboratory data. So these are some of the projects that I've been involved in. And I guess to sum up, what I would say is you got to find what you love. It may not be a linear path. Sometimes it's better if it's not a linear path. Along the way, there are a lot of people, and I've mentioned some of them, who were guides, mentors, teachers, my students who were just incredibly smart and always wonderful. And of course, you know, I mentioned that my father is or was responsible for actually developing the New England Regional Screening Program for hypothyroidism in New England and Massachusetts. My mother, for many years, ran the insurance agency that purchases health insurance for the Commonwealth of Massachusetts employees. You could say that I was genetically condemned to my career in some respects. But you know, I never would have been where I am without their leader, their just example and the kind of ethic they brought and have continued to bring to their careers. So I wanted to keep this to an hour, I believe is what I was asked, Minahil. I don't really have anything else to say except to thank you all and to urge you just to follow your heart. And I'll stop there. And happy to answer questions.
Thank you for your mentorship and teaching, Dr. Mitchell. We will now begin our Q&A session. To start off our Q&A, we are curious to learn more about occupational health training, as it is the first time I'm hearing about it. After researching more, I've learned that occupational and environmental medicine is another board exam you can take, similar to internal medicine. Did you receive a board certification in occupational health? And how long was the training?
Good question. So there are residencies in occupational medicine. I was actually the residency director at Hopkins for a number of years. The American Board of Preventive Medicine is the board. It is a board like the Board of Internal Medicine or Board of Surgery. The training is generally 2 years. There is a didactic component, which is an MPH generally. And then there's a clinical component, which is a series of practicum rotations. Many people, myself included, and I encourage people to do this, did another clinical specialty or clinical training. Generally speaking, at this point, I believe it's still true that the board requires at least one clinical year in a clinical residency, clinical training program before you enter the preventive medicine residency program. But I think I encourage people who are thinking about careers in occupational or environmental medicine or preventive medicine to utilize their clinical training wisely, because I think that experience of understanding the clinical environment helps inform your preventive medicine training.
Thank you very much for that answer. The next question we have is, why did you choose to pursue internal medicine residency as your clinical medicine training over other specialties?
Very good question. I think because internal medicine, partly because my interest in toxicology was best suited to internal medicine. It's a little harder to think about surgery or other specialists spending as much time in toxicology as internists do. However, family practice, pediatrics, psychiatry, we've had preventive medicine and occupational medicine people who have come from all of those specialties. And it's really, you know, I love internal medicine. But I would certainly encourage you, again, follow your heart. If you love pediatrics, there's every reason to see that as a clinical specialty equally appropriate for preventive medicine.
All right. Thank you very much for that answer as well. With the rise of combined MD and JD programs, some students were curious to learn about why you didn't choose to pursue an MD JD instead of your master's degree, especially since you had a higher LSAT score.
That, I have to say, not so much does the world need another lawyer, because I think, or does the country need another lawyer, because I think the answer to that is self-evident. There were not a lot of combined JD programs when I was doing my medical training and residency. And I actually toyed with the idea, but it was a lot harder to do then than it is now. And I think, it is certainly appropriate to think about a JD or an MBA, as I know some of you have already done or are thinking of doing. All of those degrees that deal with organizational behavior or law are certainly useful adjuncts to a career in preventive medicine or public health.
Thank you very much for that answer as well. Now, I've been curious, what is the relationship between the state departments of health around the country and the CDC or other federal partners?
So, the CDC, the U.S. Centers for Disease Control and Prevention, which, if you think about the organization at the federal level, the National Institutes of Health is the research institute or institutions. The National Institutes of Health are the research institutions for health in the country. The CDC is the applied public health agency for the country. It funds a majority of the federally funded activities in state health departments. It helps to coordinate state to state and multi-state efforts. So the Centers for Disease Control includes the National Center for Injury Prevention and Control, the National Center for Environmental Health, which includes the Agency for Toxic Substances and Disease Registry, the centers that deal with infectious disease, the centers that deal with chronic disease. So they are parallel to the National Institutes of Health, but where the National Institutes of Health spend most of their time working with and funding activities in the academic sector, the CDC spends most of its time interacting with and funding activities in state health departments.
Thank you very much for that answer. That explains a lot. Do you believe that the public health sector, especially from your MPH degree training, is equipped to lead during times like the pandemic? Or do you believe that we are more equipped to handle the next pandemic than we were for the last one?
Oh, that's a question that a lot of people are asking now. I think we saw a couple of things during this pandemic, which we had also seen, for example, in H1N1 and other previous pandemics. Number one, it's really important to have a strong federal presence. We saw what happened when there was not a strong federal presence at the beginning of COVID, and I will tell you that it was not a pretty sight. What we learned during that is that when you don't have a strong federal presence, the states will rely on themselves. I have to give credit. The Rockefeller Institution actually stood up an effort to try to create state-to-state collaborations around diagnostic testing and the development of testing. Other institutions similarly, academic institutions work together, but the lack of a coordinated federal response at the beginning of the pandemic was really, really distressing for many of us, and caused a lot of redundant things to happen that weren't really helpful to our overall response. I think that you have to remember what's happened to public health in this country over the past 3 to 4 decades has been a series of disinvestments and inadequate funding. And that has led to a number of problems. The problems with informatics, we're way behind the private sector and the academic sector when it comes to informatics. We're way behind with respect to physical infrastructure. We're starting to address some of those issues, but we've also had, and my comment about workforce is equally true for other parts of the public health workforce. People have been interested in public health, but it's been very difficult to have people come to work in state and local health departments. A lot of that is related to salary competition and what's happened with state salaries across the country. A lot of it is related to people don't necessarily feel that they want to come and work in a place for a long period of time. I really want to emphasize the thing, if your expectation, and I'm afraid that I have seen this over and over again, if your expectation is that you're going to come to a place and see a change in a year or two based on the work that you do, you are going to be sorely disappointed more than you're going to be very happy. Being in any job, but especially in a job like public health, means you have to be in it for the long run. You don't see changes in less than 3 to 5 years, ever. Things don't move that quickly. And if you require the kind of gratification that is, I'm afraid, partly a function of the way we consume information and the way we consume news and the way we live our lives today, if your expectation is that you are going to come in, make a change, and see things in a year, that is never going to happen, and you're going to be very disappointed in your career in many respects. Then this may not be the career for you.
Now, as a follow-up to that question, you said specifically that federal involvement is one of the reasons that could have prevented the pandemic becoming as bad as it did become. How does the Department of Health manage dealing with people who are opposed to the federal government getting involved with issues like this?
Well, one of the things that we've seen over the long run is that there are cycles to almost everything. There is a pendulum swing when it comes to public attitudes. And in some respects, I think, I do believe that we are seeing ourselves close to the end of a pendulum swing with respect to the sense of the public's distrust and mistrust of science, scientific authority, the scientific method, government authority. Now, it's possible we could go off the deep end and none of this will matter very much. But I think nothing focuses the mind like a crisis. And we are about to see many crises as we see climate change and other things happen, and political crises as well. I think what you will find over time is gradually people will recognize that the alternative to having a thoughtful discussion about the public good is to have anarchy. And anarchy is not going to be good for anybody. So I don't know that we're going to solve this problem. We may get quite anarchic for a while, but I think eventually it will come around.
Thank you very much for that answer as well. When it comes to public health, public environmental health, how do you manage the challenge of dealing with people who downplay the issue of climate change? You already mentioned a little bit about it being a pendulum swing, but how do you manage it currently?
If we're going to solve the climate crisis, we have to reorganize the way we live. And I said at the outset of this talk that we have to recognize we are not the masters of nature. We don't control our environment. We don't control the law of thermodynamics. So to the extent that we can figure out how to accommodate to the changes that we've baked into the atmosphere, we will avoid the kind of chaotic population displacement, mass famine, and warfare, frankly, that is likely to come as a result of not accommodating to those changes. So again, climate deniers eventually will be in a position where they're facing flooding, and they may deny that the flooding was related to climate. That doesn't change this fact of the flood.
Thank you very much. The next question also relates a little bit about how the public may react to some issues. So you mentioned earlier how you mandated tests for lead. Now, when you introduce mandatory testing in general, anything like that to lower income families, how do these families react to the test? Do they not have to pay for tests or anything like that?
So no, they do not have to pay for the tests. They're actually covered as part of the child visit, and they're completely covered by Medicaid and the Maryland Children's Insurance Program. But you raised another issue, which is the cultural sensitivity and competence of the people who are administering the test. I'm a white male doctor. Nothing's going to change that. But I think one of the things that we really are trying to do is create a more diverse environmental and public health workforce, because people who administer the tests oftentimes are interacting directly with these families, and having faces that they recognize, come from the same places they do. That's one of the reasons we really do stress the importance of community health workers in our asthma and lead home visiting program.
Right, thank you very much for that answer. What is the public health impact you have made that you're most proud of in Maryland?
The Clean Indoor Air Act regulations successfully allowed the state to essentially stop smoking indoors, except in private homes. And that was a significant contribution to kids' health and adults' health. The asthma and lead home visiting program that we've developed is now a model nationally for how to think about going into homes and using funding from Medicaid and CHIP to do that. And I think the work on workforce and on informatics is sort of at the cutting edge of thinking about how we're going to be prepared to do environmental health in the future. But, at the end of the day, I wouldn't say I'm more proud of one of those than the other. What I would say is two things. The first is, in some ways, if I can spur people to be interested in careers in environmental health, that for me is a terrific reward. And the other thing is, you can tell from my CV, I have trouble focusing. Let's be fair about that. And so to ask me to pick out one of these things, I am relatively proud of this body of work, because at the end of the day, I think it's allowed me to work with a lot of people and to get some good environmental health work done. And I don't pretend that it wouldn't have happened with somebody else, but the fact that I was able to do it was for me really gratifying.
Okay, thank you very much. And our final question, given you wear multiple hats in public health, how do you manage your work-life balance?
Well, you'd probably have to ask my daughter and my wife that question rather than me. That is not an easy thing to do. I still play trombone. I said we had a jazz band in medical school. I'm still playing in a jazz band. And we do occasionally vacation. But I think that, it's a little hard to have perspective on that after COVID, because for the last 3 years, we've basically been 24/7, 365 for a lot of that time. So I think if I were a healthier psychologically person, I would tell you that we don't have a really good work-life balance worked out yet in the public health sector. because we were short-staffed and it's a challenge to get all the work done. There's no getting around. You have to take time for yourself. And the department is beginning to acknowledge that we're going to lose more people if we don't allow people mental refresh.
Thank you
So
very much.
that was a tough answer to give at the end, but a really good and important question.
Yeah, but still, thank you for your answer. One thing I forgot was to introduce myself earlier. My name is Hamza. I'm a student in the LECOM BSDO program in Western Pennsylvania, and I'm really interested in pursuing public health after residency potentially. And learning from
great.
you really helped me see myself in a career like this someday. So thank you.
No, I'm delighted. I love this career. I really do. I mean, no one in the public health department has as much fun as I do, frankly.
All right. Thank you, Dr. Mitchell. These are all the questions we have for today.
Yeah, and thank you so much, Dr. Mitchell. We really appreciate you taking the time to answer all of our questions today and taking the time out of your day to mentor us. And I'd love everyone to please give a warm thank you to Dr. Mitchell in the chat box for this incredibly informative session. Thank you.
It was really a pleasure, Manahil. And it's really a pleasure to meet all of you. Happy to hear from you. And Manahil, you can put my contact information in the chat if you want. It's cliff.mitchell@maryland.gov. I'm happy to hear from you if you're interested in careers in public health and environmental health.
Thank you. Thank you. I just shared it in the chat box.
All right, now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live. And again, you will need a 70% or higher to pass and receive certification. And that link is in the chat now. Now on to our next session dates. These dates will also be posted through our social media outlets at TeleShadowing, so be sure to follow us. I'm looking forward to seeing you all next Saturday, October 22nd, with our physician mentoring us in emergency medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.